Over the years that we've held the ABSARD meetings, we've had repeated feedback that one of the most fun and enjoyable and informative parts of the meeting is a chance to talk to experts about how they handle complex situations, cases that are not written about in the literature or for which there are no real great evidence-based trials. Because as you all know, evidence-based trials tend to be very selective, and we can't be selective in clinical practice. We have to see whoever comes to see us and sort things out. So let me just introduce our panel to be sure that if you haven't already met them. So immediately to my left is Dr. David Goodman from Hopkins, a world-renowned expert in adult ADHD. We've got Dr. Mary Salanto, who's been moving around New York to different programs, is now at NYU, and who is a world expert in adult cognitive behavioral therapy. Next to her, needing no introductions, Dr. Len Adler, also from NYU, and Dr. Richard Gallagher. We got an NYU heavy panel here. We've got Dr. Jim McCracken from UCLA and myself, and I guess I sort of switch hit because I see kids and adolescents and adults. And I'm Tony Rothstein from Penn.
Yeah, hi. In one of the slides, and I know we know the statistics, is that an awful high percentage of people go off their medications after a certain period of time, and I'm wondering if from your practices you've got some pearls or data on how you keep people on the medication, and if when they go off the medication, does that also mean they stop coming to you?
Jim, would you want to start with that? I don't want to put you on, but this is a big issue for us, treatment adherence, and maybe start with the child, and then we'll move up to the others.
Sure. Well, what comes to mind are parents of patients who, from the get-go, have a great deal of ambivalence about using medications for their children. Even when I've felt that we had gone through the necessary observations, if you will, to determine that they indeed were working. We saw grades improve, et cetera. I think what, at least in my experience, can happen is when those misgivings or ambivalent feelings or whatever are not continually sort of brought up into the conversation, that you will find that it's more likely that those parents will just sort of disappear, and that with that the child will drop off of effective treatment. I don't have any kind of nifty psychological tricks to persuade them to keep going with it, other than I do go the extra mile in those situations to maybe collect more information, more teacher observations, review in even more detail the progress reports, et cetera. And I guess the last thing is obviously any kind of side effect is going to greatly undermine everybody's commitment or investment in taking the medication. I think sometimes from a medical standpoint, we sort of trivialize the side effects that are pretty common. Even the sort of mild stomach ache or the complaint of a little bit of dysphoria. So I think we really should pay closer attention to those kinds of things and really try to fine-tune, to do whatever we can to reduce those. And I think that will play a significant role in helping adherence.
So for adults, adherence is a big problem. And I think part of the discussion is about setting expectations. Yeah. If we have unrealistic expectations of what the medicine's going to give, we're doomed. Even for stimulants, there's a perception that you're going to give a dose, the light switch is going to flick, and then everything's going to be great. The curtain's been lifted. And That's just not the case. You know, if you're going to try to improve tolerability and adherence, you've got to start off on a lower dose and titrate to some extent. Now, we're not, you know, how we titrate stimulants is different from how we titrate non-stimulants, but, you know, we don't put everybody on their full therapeutic dose to start because many of the adverse events that are seen, you won't get the accommodation you will if you sort of build up the dose, and the right amount of medicine is the least amount of medicine. So that needs to be part of the discussion, and it's not something that happens kind of quickly. It's really done, you know, trying to do this in a thoughtful way and trying to individualize this for the, you know, make it a partnership with the patient in front of you. When it comes to the decision of stimulants and non-stimulants, I think that, again, it's an expectancy issue. And have they taken a stimulant before, and what are they expecting of getting out of it? And if you're going to give them a non-stimulant and they're going to expect for it to feel like a stimulant, well, it's not going to happen. If you have a patient with very severe ADHD and you're giving them a non-stimulant and they want to have that effect size of 1, it's not going to happen with a non-stimulant. So all of these things have to be framed in the discussion, and also an honest discussion of what the potential adverse events are. If you prepare people for what might come, they're not surprised, and if you prepare them that accommodation will occur, they're more likely to stick with it. I also think setting up parameters in terms of what you expect in terms of follow-up is critical. For stimulants, how often are they going to be seen? What are we going to do to monitor them? What are the regulatory requirements? All of those things are part of this discussion. How often are you going to have to see them down the road? Because if you set up a paradigm that the patient's not going to be able to comply with, it's not going to happen.
I'm just going to complement what everybody else is saying a little differently. At the end of my evaluation, before I tell them what I think and what I suggest, I say, if you had 3 very specific things that you would like to see change on a daily basis, what would they be? I want my mother to leave me alone, I want to get an attractive girlfriend, and I want A's in school. We're on a different page. So the expectations of what the patients are, I have to buy into and say, can I do that or can I not do that? So that's going to lend setting the expectations. The other thing about side effects is that patients will tolerate side effects acutely, but 3-6 months down the road, that same side effect is no longer one that they're willing to tolerate. So it's important to track the side effects and then get some sense of their resistance to tolerating that side effect that they've had for a long time. The other aspect is things with dry mouth. If they go on chronically, they do present dental issues. You get gingival recession, you get increased dental caries, you can get teeth clenching and jaw grinding. And so those become major problems over a longer period of time.
2 simple things you can do, because the medicine does cause some drying, as David mentioned, is, you know, you can use some of the, you prepare patients for this. Proper hydration is critical. These medicines cause some drying. In addition to the tachycardia that occasionally occurs, all of them will increase the heart rate to some extent. And if patients aren't drinking adequate fluids throughout the day, I've had patients, you know, have syncopal episodes just because they're dry. They just forget to drink. And you've really got to pound that home. That'll improve the tolerability. And also some of the stimulating mouthwashes or toothpaste that can stimulate saliva flow. The other big thing is to limit caffeine. You know, caffeine in terms of the potential cardiovascular effects, especially on heart rate, is pretty dramatic when you add it onto both atomoxetine and stimulants. If you got to take the caffeine history beforehand to know what the patient's taking. If they're drinking, and I've had patients that have gotten through college not very well on 2 cases of Diet Coke a day. If you go from that to no caffeine, you're going to get a whopping headache. So you've got to kind of prepare them to kind of lower the dose of the caffeine in a regular way. But it really does improve tolerability. And will deal with some of the increased heart rate and agitation issues if they super add the caffeine on.
So to pick up on the dry mouth, I know we're just go on, and poor people here are getting hemostasis in their legs. If you really can't overcome the dry mouth, there are two things that you can prescribe. One is pilocarpine, which is oral pilocarpine. You can use BID or TID. If that doesn't work or they get skin flushing, you can use a medication called Evoxac. It's EVOXAC. It's approved for xerostomia, for radiation, for neck and head cancer. And that sometimes also overcomes the dry mouth, because sometimes the dentist will say, this is a real problem, and I can't get by on a lower dose, and you'll have to change my medicine. If you've worked hard to get somebody on a medicine that really helped, it's best to try to overcome the side effects. And those are two suggestions on that. On the caffeine, when you're checking blood pressures and pulse, I always ask patients what their caffeine load was before I check their blood pressure and pulse, because if I get a blood pressure or pulse reading that I'm concerned about, I need to know if that's contaminated by their caffeine intake that day.
Okay, and I just want to add one last idea, which is we do not prescribe until the patient has come back and done some reading about ADHD and has gone to a website or comes with a question from the reading they've done, because we think that unless the patient is showing that they're taking this disorder as what it really is, it's not a methylphenidate deficit disorder. It is an attention and lifespan disorder. And so really engaging the patient, we try to assess their readiness for treatment. And especially with the college and transitional age youth, when they've been all their lives have someone pop the medicine in their mouth, and now no one's there to wake them up and no one's there to give them the med. We spend a lot of time explaining, like, okay, chances are you're going to forget meds. Maybe you're going to stop them for a while. I'm still here. I just got an email from a patient who saw me in deep trouble. He's a Penn student, and he vowed he was going to come and see me every week, and of course he stopped seeing me after about mid-October. Finally, his mom wrote to me and said, I know that, so-and-so's not come to see you, and he says he's having trouble getting into you. And I said, just have him email me. Well, the next day he emails me. He's coming to see me later this week. And I kind of expected it when I met him. I kind of knew that about him. I didn't want to tell him. I just had that. My mind frame was, I don't expect consistency from inconsistent people. So to expect consistency in adherence, and the other thing I was going to echo with what Jim said is with the parents, is if the parents have ADHD, they're going to be real tough to kind of stay with treatment. So we try to detoxify non-adherence and say it's kind of the rule rather than the exception. So we don't want to penalize you or make you feel bad, because they don't want to come back saying, well, Dr. Rothstein, I really didn't like your medicine, or I didn't take it. So that's really how we try to sort of destigmatize, if you will, non-adherence, and make it sort of realize that, yeah, it's hard to just get things done regularly anyway. We want to help you, but we're here to figure this out. So it's a joint problem-solving model, rather than we're the doctors and we're the therapists and you need to do what we say. Okay, everybody, thanks for your attention, and please tell your friends about this organization, fill out the forms, and hope to see you next year at our meeting. Take care.